of type 2 diabetes. Tonight we're going to be having a chat mainly about lifestyle, but it's also about empowering you as well to make changes to yourself and for us to guide you through that. Can I have the next slide, please, Dion?
Sorry, Dion, can we pop that into slideshow mode? Because at the moment we're seeing the bit down the sides.
There we go. Thank you. Thanks, Dion. So diabetes, there's two types of diabetes. Actually, there's more than two types, but generally speaking, there's two types that we are going to talk about tonight. Type 1 diabetes is where you do not produce any insulin at all. Insulin is a hormone which regulates your blood sugar levels. Also, we talk about it as your blood glucose levels. Type 1 diabetics, it tends to be a younger adult or a teenager, and they present where the body doesn't produce any insulin at all. So it tends to be an acute presentation. It tends to be, it's quite serious. But tonight we're going to talk about type 2 diabetes. Type 2 diabetes, you do produce insulin, it's just the body's not producing it either effectively, efficiently, or the body cannot access the cells that your insulin cells there for specific reasons. The most common reason for type 2 diabetes tends to be in the or self-present to A&E. But generally speaking, for both type 1 and type 2, the main symptoms are increased excessive thirst and tiredness and infections. Now, for type 2 diabetes, it tends to be either it's very subtle, you have no idea that you have it, it's picked up in a routine blood test, or you think, oh, there's a family history of diabetes that can make you more predisposed to it. It could be you have urine infections, recurrent infections, and we might do a blood test and it's picked up then. Some people, along with infections, excuse me, I'm going to take some water, urine infections, might present with thrush, either oral thrush or genital thrush. That will then lead to, we might think, okay, let's dig a little bit deeper. What's going on here? And then we pick up diabetes. Other symptoms could be blurry vision, and it could be in some people tingling in the hands and feet in particular. So it can be very subtle, or you might come in and say, I'm really, really thirsty. I'm suddenly really thirsty. I'm up in the night going to the toilet. Something's not right. And then it'll be picked up then. Can we go? So going on with that, with these high levels of sugar levels going around your body, it can lead to other complications. Now, it can be, it affects your blood vessels. So big blood vessels, it can damage the lining of the vessels, and it can damage the lining of the smaller vessels, your capillaries. So it, for instance, your eyes, the blurry vision, it can damage the back of your eyes, and that's called retinopathy. When you present with the tingling of your fingers or your feet, that can be nerve damage, and again caused by the diabetes. It can affect your kidneys, and then we're going on to the bigger problems like the heart disease. It can go on to cause complications, and it increases your risk of heart attacks and strokes. So diabetes is a huge topic. It's not just about sugar levels. It has a knock-on kind of domino effect to other complications in your life. The other thing, just to quickly mention, I don't know if I said, non-healing wounds as well. If you've got a wound that just doesn't heal, particularly on your legs, the nurses might think, hang on a minute here, they might swab it, but they might say, let's do some blood tests again to check for diabetes. Can I have the next slide, please, Dion? So we tend to diagnose diabetes with a blood test. This blood test is called a hemoglobin A1C. It's a bit of a mouthful. It looks at the energy cell that's attached to your red blood cell. And that red blood cell, the lifespan is 2 to 3 months. Hence why if you are diagnosed with diabetes, we start you on either lifestyle changes or medication changes, the minimum we tend to repeat that blood test to track your progress is every 3 months. I thought I'd mention that because some people get quite frustrated that they've made changes. They want another blood test in a month to see how they're getting on. As I've mentioned before, type 2 diabetes tends to be present in the older patient. And going on into elderly patient, that age group, your body just unfortunately doesn't work quite as efficiently. The pancreas, the little cells that produce insulin, get a little bit tired. They're trying to keep up with the pace, with what's coming in, the sugar that's coming in. They get a bit tired. So then you get the subtle symptoms of the increased thirst and what have you. We are seeing type 2 diabetes present in the younger, under 40-year-old patient. Again, it tends to be always generally linked to being overweight. We are seeing teenagers and children now who are overweight, who are being diagnosed at an earlier age of type 2 diabetes, and that's something that we want to address. We're going to go on and talk about being overweight. As I mentioned earlier, is that, sorry, I keep pointing to my belly, you can't see, it's that middle tire that we tend to see around your waist. Again, not everyone is like that, but generally speaking, we're being very generalized here, tends to be the case in most patients. Can we go on to the next slide, please? So the Leicester Diabetes Centre did a big study, and their outcome, their findings or to the study found that having this 5-step S approach really makes a difference to individualized patients with type 2 diabetes to regain control of their diabetes through certain activities. Dion, if we could nip over to the next slide, please. It's quite a wordy slide, but it does encompass what these 5 S's are. So for this sitting, for those that are maybe have desk jobs or what have you, they recommend you get up, move around every 30 minutes, stretch, get the body moving, get the circulation flowing. Stepping if you can, if you're physically able to, increase your steps if you can. Just get, again, the circulation going. Any form of exercise will make you naturally produce insulin. And I always say insulin's a bit like Pac-Man. It comes along and chops up the excess sugar levels that are in your body. I'm being very general here, but it just all helps. Exercise is really key to your well-being, not just for diabetes, mental health as well, sleep. If you don't get a good night's sleep, the next day you struggle, you can feel low in mood, your energy levels are low, and then you reach for the nearest thing, which might be sugary snacks and what have you. We'll go on to diet in a little minute. So a good night's sleep is key. I did want to mention as well, since we're talking about a fairly holistic approach tonight, if you are having trouble with sleep or either falling asleep or staying asleep, we do have, we can refer you on to what's called the sleep station, where there's support there for you. And again, it's individualized. But going back to this exercise now, if we do, studies have found, if we do a short, sharp burst of 20 to 30 minutes exercise, 2 to 3 times a week, you naturally produce more insulin. It helps bring your sugar levels down. We're seeing this time and time again. I know some people might not be able to do that for whatever reasons, maybe arthritis or what have you, but get a couple of tins of beans, start doing armchair exercises. There's lots of videos now, so I'm taking another drink, for exercises in the armchair. If joints are a problem, like I was saying, swimming's very good for you as well, just to get you going, get you moving, again, get that circulation going, get your blood pumping around your body. You feel better for it all round. I think I probably covered the 5 steps. So the other thing I was going to mention was even just put the music on in the kitchen, have a little dance, whatever, just to get you moving. Improves mental health as well. It's again, having it, the idea is with these 5 steps, with the 5 S's, this is in a 24-hour period. Obviously, I've mentioned exercise 2 to 3 times a week, but if one adopts this, they say what a difference a day makes. It really does. It makes a difference for you all round. Can we pop back to the previous slide, please, Dale? Thank you. Diet. Now, everyone will often, if I had a pound for every time somebody came in and said, I don't eat sugar, I don't eat sweets, it's not just that. Everyone has a little sneaky snack every so often, sweet tooth. That's fine. You've got to live and enjoy yourself. But it's in moderation, everything in moderation, not excessively. Sugary drinks. A lot of the marketing out there say sugar free, but then they'll have artificial sweeteners in there and certain fizzy drinks. Fresh orange juice or fresh fruit juices, you think you're being healthy, loaded with sugar. I can't remember what a glass of fresh orange juice is. It's something crazy like 8 tablespoonfuls of sugar in there or something. It's really excessive. Diet. We as a nation, I think we eat a lot of carbs. We have carbs with everything. And when I talk about carbs, I'm talking about your, and white ones in particular, white rice, your obviously your potatoes, but chips, what have you, white bread. You're lovely. You go past the bakery or you're in Sainsbury's or Waitrose or wherever, and you smell the lovely bread, the baguettes, and you think, oh, I could just have some of that. You metabolize that really quickly. Your sugar levels rocket up, then come crashing back down, and then you're hungry 40 minutes later, an hour later, and you think, oh, I've just eaten and it was a lovely baguette or whatever, but I'm hungry. This is the problem. If we were to, we recommend going for the brown breads, the seeded breads, the brown pasta, the whole wheat, wholemeal pasta, brown rice. I know it's a bit nutty at times, a bit chewy, sorry. But these, you metabolize them slower. You don't get the yo-yoing up and down of your sugar levels. Metabolize it slower, you feel fuller for longer as well. So you're not reaching for a quick fix after an hour after you've had your sandwich or baguette or whatever. Um, they do recommend more of a Mediterranean diet. So your plate, try and divide it into quarters. The quarter of it is your carbs, and then you want your protein, so your fish, very good for you, or your meat, whatever, and then fill up with your veg as well. Fruit. Fruit is a big thing. Your berries are a better option. So your blueberries in particular, or your strawberries, raspberries, whatever's in season. I have come across several patients who would eat a melon a day, and I thought, blimey, but she knocked the melon on the head and the sugar levels came down. So there's a lot of lovely sweet fruits out there that are delicious, like your green grapes, um, loaded with sugar. Try to go for the berries is my recommendation. I'm sure there's other things, but I can't quite remember about that. I'll come back to it if I do remember. We often, depending on your level, when you're diagnosed with diabetes, we kind of work to target levels. We take in your individual circumstances, your age, other problems like kidney function, and what have you. But I will say, let's make dietary changes if you're not too symptomatic. And we'll go down the lifestyle route first of all, before we talk about medication. I don't always want to jump straight into medication. We can come to that. But some people do need to have medication just as a helping hand to get control while they make dietary changes. So everyone's very individual. And there are quite a few options of tablets, but there are some people with type 2 diabetes that do require insulin just for various reasons as well. So, and that does cause a lot of confusion, I think, with the public. As I mentioned earlier, I was going to mention, sorry, the main tablet that we tend to go to, it's first line in our recommendations, and everyone's heard of it, is metformin. Most people start on metformin, and not everyone tolerates metformin. Usually causes side effects, gastrointestinal, so increased wind or loose stools, but we can play around with that, go for a slow release one, or play around with the dosage. But my point I was going to make, sorry, for diabetes and type 2 diabetes, you can come off medication. I love it to what we call deprescribing. It really empowers patients as well. When they come in, they've made massive changes, turned their lifestyle around, and we can say, right, your levels are right down. Let's talk about knocking down your tablets gradually, because that's empowering. It's encouraging, it's very motivating as well. Um, when I mentioned other complications earlier on, when I was talking about, again, that kind of fatty layer in your abdomen, it can affect your liver. We often see patients with fatty liver, non-alcoholic fatty liver, which can cause problems. And again, that fat is around your pancreas as well. But as well as your middle area, you've got fatty deposits going around in your blood vessels, your arteries. And one of the problems with diabetes is you've got an increased risk of strokes and heart attacks. They tend to be because you've got high cholesterol. And high cholesterol, um, you have these fatty deposits in your arteries. It's very attractive to it gets built up and it causes problems later on. It increases your risk, as I said, of the heart attacks and strokes. I always say to patients, when you're born, your arteries are squeaky clean. Throughout life, diet, lifestyle, smoking, whatever, you get these fatty deposits, these what we call calcified deposits. We often chat about statins. Statins have a big role in controlling your cholesterol and reducing your risk of heart attacks and strokes. I often say to patients, the Daily Mail normally runs a piece in statins every few months. But there's a lot of studies out there advocating statins as well. You can make changes through diet again and improve your cholesterol, but statins, I was just going to say, really do help reduce your risk factors for later on in life for heart attacks and strokes. So usually when you have a diabetic review, we'll talk about cholesterol as well. Other complications, it's just occurred to me, I've not mentioned this, blood pressure. Again, that goes generally hand in hand with, probably I'm being a bit blunt here, but with being overweight, generally bumps up blood pressure as well. And then you might have to have medication for blood pressure. It's just a knock-on rolling effect, but you can do something about that by turning your life around, being more active, and looking at your diet. And we're here to help you, and we can refer you for dietary education or for weight loss or what have you. Um, the complications, the other thing that, again, going back to the beginning when I said you get problems with the presentation, it might be nerve tingling in your legs, in your feet. You might need medication for that to help because it's keeping you up at night. So again, it's additional complications with diabetes. Excuse me. We have the next slide we talked about, I think, Dion, was that one. So if we pop over onto the next one, please. So remission. Now, you can achieve remission. I generally say it's more what we call diet controlled diabetes. Remission's quite a big word, and um, it's quite a big thing. Diabetes never goes away. It's always going to be there, always going to be there, but you can control it. But if you made massive changes, we would still want to regularly review you, probably once a year, if not more than that. But that would be in agreement with your nurse or clinician. Um, I mentioned right at the beginning this blood test to diagnose diabetes. What I didn't mention was anyone with a level of 48 or above has diabetes. Pre-diabetes is a level between 42 and 47. And there are diabetes prevention programs that we can refer you for to stop you, prevent you from tipping into that type 2 diabetic bracket. Because unfortunately, once you're labeled with type 2 diabetes, you're labeled. but we can control it. I've already mentioned about the fatty deposits around your liver and your pancreas, and I've mentioned about weight loss. So weight loss, again, we can refer you if you feel that you need help losing weight. And these referrals, so there's two tiers, there's tier 2 and there's tier 3 that we can refer you. That's through your GP surgery, it's through your clinician, nurse, GP, whoever, or dance practitioner. Um, we can talk about that, look at your BMI, look at your blood results, what have you, and we can definitely arrange help for you and refer you on where need be. I wanted to talk about, I think it's on the next slide, Dion, please, is this Path to Remission programme. Now, this is a new service that's been offered in Hertfordshire. It's been available in England for a wee while. And this, you may have had a text about it. This is a supplement diet for 3 months. So it's soups and shakes, and I think cereal bars as well, but it's a total diet replacement for 3 months, and then you then have additional support over a year in total. The idea is that you are going to lose weight, you're going to kick your diabetes into remission, empower you, regain control, and come off medication as well. Excuse me. Now, the referral for this Path to Remission program, again, it's through your surgery. There is a criteria for it. It is on the next page. We're dotting about a bit. Dion, can we pop over to the next slide, please? They've done lots of studies on this and found it really is quite effective. And patients can they're motivated to keep the weight off. Um, the criteria has to be, you have to have a diagnosis of type 2 diabetes within the last 6 years, and your long-term sugar level, the HbA1c, has to be below 86, 87, I think it is as well. There's a little, it's quite fine tuning. So again, it's individualized, it's personalized, but your clinician would talk to you about that and go through that. There we go. Thank you. BMI has to be over a certain weight as well. And then there's a little section halfway down that page, excuse me, that where they will not accept certain referrals, for instance, active cancer, recent heart attack, or heart failure. But again, I'll chat about it with patients. I'll send them a link to have a read about it, and we discuss it further, and then we send a referral in. Currently, I sent somebody a referral in on Monday, and she's had contact, and she's starting in October for this program. So I really think it is quite a good service that's being offered for you. Oh yeah, and the age bracket, sorry, is not for anyone above the age of 65 or below the age of 18. But again, I would send, or your clinician would send you the information, and you go through it together and see if you fit that criteria. If you don't fit that criteria, there's the other options for weight loss referral, or there's another option, which is medication. So that brings me nicely onto that. Dion, can we pop back to the slide that I think it's a previous slide, yeah. Yeah, and so bariatric surgery, to be enabled for bariatric surgery, there's quite a strict criteria. Again, you would need to, it's over a certain BMI, you have to go through certain hoops to get to that stage. But again, you would talk to your clinician about it. Weight loss drugs. Now, weight loss drugs, you've probably heard about it. It's all over social media. It's all in the news as well. A lot of celebrities are getting hold of this drug. Now, this drug, we're dotting on again, Dion. I think there's a slide further on that mentions the medications. Yeah. So the medications, we've got two choices. First of all, orlistat. So orlistat basically stops your food that you eat stops the fat from binding, and so it has to be excreted. and I'll leave it at that. Okay, can be a few problems with that, but again, you would talk to a clinician about it. Moving on to the weight loss drugs. So if you have diabetes, and we've explored medications, we kind of work our way up a little ladder for medications that we would discuss and prescribe for you. Not everyone fits the bill for each of these medications, but the medications for weight loss. So generally speaking, it's a once weekly injection. Um, there are some medications that are once a day, but there's such a huge, as it says there, supply issue. And also it says your BMI has to be 35 or above. I think they recently have dropped that, but your BMI generally has to be above 30. Um, Everyone's interested in it. The contraindications to would be if you've ever had a history of pancreatitis or if you've got retinopathy. So that's back to the damage to the back of your eyes. So again, it's an individualized plan. Speak to your clinician and we would look at it. There are newer medications coming on to the market, which are very efficient. But the mode of action for these weight loss injections, basically, they work on a hormone, make you feel fuller for longer. You don't eat as much, you lose weight. I'm being very basic, but that's how they work. Okay. And we would work together. You would need regular checkups and what have you. There are a few side effects with it. You can have nausea, you can have vomiting, you might have abdominal pain, constipation, what have you. But again, your clinician would go through all that with you and have a chat with you about that. That's the final slide, but I just want to dot back. I'm sorry, I'm so sorry we're dotting around these slides for everyone. I just want to check I've covered all bases. I think I have, but it's just going back. Oh yeah, this one here, exercise alone won't cause remission. Now, it's a bit debatable. You would have to go for extreme exercise, and I can think of two patients off the top of my head, uh, both men, both in their late 40s, and both really did not want to go on any medication. One of them was a police officer, actually, really didn't want to go on medication, went out, bought a rowing machine, completely turned it around. His HbA1c, I think from memory, was 97, and he got it down to 48 in 3 months. So, and that was, he did obviously modify his diet, but he, I think 5, 6 nights a week, he was on that rowing machine. That's an extreme one, but I do see it time and time again. Exercise really can change things for you, really can turn your life around for you. No matter what age, whatever, you can do it, definitely. Um, I think that's it. I think I've covered most of the slides and most topics. I don't know, Tara, if you've got anything else to add.
Thanks, Debs. Hopefully that's now showing the questions slide. So you're quite right. Exercise is really a really important adjunct to all of this, and I would encourage everybody to exercise. In fact, we had our staff training day today, and they were encouraging us as staff that we need to exercise more as well. Lots of us have very sedentary jobs. We're sitting at desks seeing people all day. The practice that I'm at, Port Mill, is in theory a parkrun practice, and that's a really great way of getting active among other people on a Saturday morning. But I suspect that your patient who started rowing probably lost weight as part of being so active, and I would probably argue that the weight loss was the main reason that his HbA1c improved so much. But absolutely, exercise can be a really important part of that. And as we've said several times, also really good for your mental health as well. So I think this is the first time that we've had an education event where nobody's put any questions in the chat as we've gone along. Usually we've got hundreds to go through by the time we get to the end, which would suggest you've done a fantastic job in explaining all the options that are available to people. But if anybody has got any questions, please do pop them in the chat, or if you're feeling like speaking, then I'll stop muting people if you've got questions.
I just wanted to say, if you feel you've not had a check, contact your surgery, see if we can arrange a blood test for you. There are lots of services out there to help you. Your clinician definitely will be aware of, there's, I didn't even mention exercise referrals as well for certain areas. I know in Hitchin we have, used to be Archer's Gym, but it's now Everyone Active.
Yeah.
We can do a referral there. There's so much out there, and we're here to help you. We're here to help you, empower you, and have that overall holistic approach to your care and to your diabetes as well.
Mm. Yeah, and there is the NHS Digital Weight Management Programme. There's a new weight management programme that's about to come online. It may have come online today, actually, that's delivered through a slightly different provider for tier 2 and 3 services, so which we haven't had access to for non-diabetics for a while. So we've got lots of things that we can help with. And I think that, diabetes, it is really common. And so I think maybe the importance of it is underestimated, but the long-term complications can be really huge, and actually partly because it is linked with being overweight. Those lifestyle changes that you can make can be so positive in other ways, whether that's on your joints, on your breathing. I mean, my mum is very overweight, and she recently managed to lose 2 stone, largely, Debs, by cutting out white bread.
There we go.
And she was saying how much that's just meant that now she can be more active because she's able to walk further without her knees hurting and without feeling short of breath.
Yeah.
So we've got a few things here in the chat. Been waiting 3 years for knee surgery, so can't exercise. That is a real problem, and we've just been talking today about how we might be able to help do other things to try and reduce the waiting lists for elective surgery. I mean, sometimes there are short-term alternatives like having joint injections, which might be a possibility. But as Debs was saying, it's definitely worth thinking about even chair-based exercises, whether that's just moving your arms, lifting, having weights in your arms and doing those seated exercises, whether swimming might be an opportunity, or those kinds of things. So we've got a question here. What do you think of glucose monitoring like Zoe, Limbo, Lingo, etc.?
I've heard of Zoe, never heard of the Limbo or Lingo. Have you, Tara, heard of the Limbo and
No,
Lingo?
I've heard of Zoe as well, but not the other two.
No, I think any monitoring empowers you.
Mm.
What I was going to suggest, if you're online now, so you would have access. Go to diabetes.org or Diabetes UK. There's tons of information on there. They would explain if you did decide to monitor your sugar levels, you can go and buy yourself a machine. Um, we would give you a machine if you're on certain medication that cause hypoglycemia, but that's a different topic. If you are going to test your sugar levels, you need to understand what you're testing. So go to these Diabetes UK websites or diabetes.org, and they explain it all there. Lovely explanations of what your levels are, why they're like that. It just gives you a better insight. Again, contact your clinician. We'll be happy to talk to you as well, talk you through it as well. And that's
Uh,
often when the penny drops as well. Sorry, to when
no,
if
no.
you, I often say, do it first thing in the morning. You want a fasting sugar level, and that's your baseline. Go and have your breakfast. Say you have your fresh orange juice. Just say, check your sugar levels. Maybe half an hour, 40 minutes later, you'll see it rocket, and then the penny drops. So wherever it is, the penny will start dropping. Oh, look at my levels after I've eaten or drunk whatever.
So yes, the question about will the webinar be available? All of these education events that we run for the Primary Care Network are on the PCN website, so you'll be able to watch this at your leisure later, once Dion has edited it so that we haven't got everybody's pictures in view. We've got a question here. What do you think of empagliflozin and Ribulus, which is, I'm sure you already know this, but it's semaglutide?
Yeah. So empagliflozin is an SGLT2, which means it basically you're passing in your urine sugar, excess sugar. It works on the kidneys. You can lose a few pounds in weight with it. It's a very good drug. There's studies now recommending this type of medication for patients that are not just in diabetes, but for heart failure and for kidney problems, kidney disease as well. It's a brilliant medication, very, very good, and it helps with diabetic control as well. Little caveat is not everyone tolerates it. It can make you go to the toilet more. It does initially because you're suddenly passing glucose in your urine, sugar in your urine. You are at risk of urine infections and thrush, generally speaking, a few other things. But EMPA in particular, if we go low dose, I tend to go 10 milligrams, tolerate that, check you in 3 months, check your sugar levels, and then we can increase it if need be up to the next 20 dose, which is 25 milligrams. So the most common ones, empagliflozin, dapagliflozin, canagliflozin, they're the most popular ones. Cardiac teams tend to go for dapagliflozin, that's their drug of
Mm.
choice.
Yeah.
Rybelsus, I think that would be, that's your, going back to your GLP-1. So that's the oral medication, the oral version of your injectable GLP-1. Again, very good, very effective. You have to take it first thing in the morning. Sorry, I'm dry again. Um, half an hour with a glass of water prior to having any breakfast, any food. Again, very effective. There's 3 doses. We start you on the lowest dose, 3 milligram, maybe increase you to 7 milligrams, potentially up to the 14 milligrams. Again, a couple of little caveats. You can't have it if you've got any problems with the back of your arms. But and you can have them both together as well. They're good medication.
Yeah, I think there's going to be moves towards starting lots of people on something like EMPA along with the metformin if there's,
Mm.
potentially other bits and bobs
That's
going on.
the
Because
change
as
in the
you say,
guidelines.
yeah, because it's so helpful for other conditions as well.
Mm.
So don't be surprised if your clinician's suggesting several things. Um, so we've got a comment here that everyone active is expensive. They only give 2 months free trial and then the charge is around £40 a month.
Mm.
Yeah, there are. I mean, and there is also a question about what the referral criteria are for the gym membership. Off the top of my head, I can't remember what the criteria are, but they're quite loose.
Yes.
In that, I think one of the questions is certainly used to be about whether actually you had your mental health wasn't great. So if you're just feeling a little bit low, that would be a reason potentially to be referred. I think there's if your BMI is above certainly if it's above 30, but it might be certainly if it's above 30, if you've got high blood pressure, osteoarthritis, there are loads of reasons why you might be eligible for that. But again, I'm not sure. It may only be that you would get the 2 months completely free, and then I thought you then got a reduced rate, but I may be wrong about that. They've changed provider recently, so I'm not entirely sure. Also, the form hasn't yet been put on our computer systems, so we're a little bit anxious about data protection. We're trying to push to get that on the system so we can easily refer people in when that's appropriate. So we've got a question here that says, what about Freestyle Libra?
Yeah, so the Libra, um, on the NHS, basically right now it's only type 1 diabetic patients that are eligible for the Libra, and even they're struggling to get it. Not everyone has access to it. The Libra, if you don't know, is a little disc that goes on your arm, generally speaking, and it's a device where you would link it up to your smartphone, and it gives you more or less continuous readings of your sugar levels, of your glucose readings. You can sign up, and I often recommend patients to do this for your 2-week free trial. Just remember to cancel your subscription so you don't get charged for that. But it gives you, there's a slight little lag. If you were to compare scanning your Libra device on your arm with a finger prick test, there's a little lag of a couple of minutes. But it does give you a really good insight into your sugar levels, the peaks and troughs, and you can compare that to your activity levels as well. What you've eaten is great, it's brilliant. Unfortunately, if you have type 2 diabetes, you're not eligible for it, and even for our patients type 2 diabetes that are on insulin are not eligible. But sometimes if they're very high risk or vulnerable, we might be able to persuade the diabetic team to let us to prescribe it. Right now, it's currently controlled by secondary care, so by the hospitals. However, I did have an email this week, maybe suggesting that we might be able to access just the monitoring side of things. Because even now, if a patient comes in, has a Libra monitor, unfortunately, I'm not able to access their readings, their output. But I'm sure that'll improve with time to come. So definitely sign up for the 2-week free trial. You get a lot of information. There's Libra and there's Dexcom as well. I'm assuming Dexcom do a free trial, but I don't know much about the Dexcom, but it's the same idea as well.
So the question that said, is the Libra not on the NHS? So it is on the NHS in Hertfordshire, but as Deb says, only for type 1 diabetics, and I'm not actually sure it's available for all type 1 diabetics. I think the secondary care do need to put forward a case before you necessarily get a Libra. One of the questions also says my sugar level goes down sometimes in the middle of the night. Can I get Libra on the National Health? And if you're a type 2 diabetic, I think what we're saying there is no. So there's a comment that it is available for type 2s in Leicester, but
And
no.
Cambridgeshire as well.
Oh, is it? Okay.
Yeah, but again, it's certain criteria, but not in Hertfordshire just now, unfortunately.
I think, if, as Deb is saying, if your clinician feels that you're particularly vulnerable and there's an exceptional reason why you should be eligible for Libra, in fact for pretty much any funding decision in our area, there is something called the exceptional treatment panel, the individual funding request team, and your clinician can put a request in for exceptional reasons to have something funded. But it won't necessarily be agreed. It has to be properly exceptional. We've got a hand up.
Hi, it's just me. I follow on Twitter the diabetes lead for the NHS. And
Sorry, Lindsay. For those who don't know, this is our practice
yes.
manager from Port Mill Surgery. It's not just a random person.
My understanding is that the commitment from the NHS is that all type 1s will have Libra. We as an area are way behind on that. And they are very upset about that nationally. I think probably moving towards more type 2s having it, but until every type 1 has it in the country, that won't be a priority.
Yeah, that would be priority. Yeah, NICE guidelines are type 1 diabetic patients, should have a Libra. But again, as Lindsay says, it's not the case yet, but it is improving in this area.
Super. I think we've answered all the questions that are in the chat so far. If there's any other questions, please do pop them in the chat, or if you really want to switch your mic off and go ahead and ask.
I think there's just one more. How often should we be getting blood tests?
Sorry,
Has
yes,
that one been
that.
answered?
No, I missed that.
Yeah.
Sorry about that. Yes, good question.
So again, it's individualized. At least once a year, if you have been diagnosed with type 2 diabetes, at least once a year. Annually, we should review you, do a blood test for diabetes, but not just diabetes, your cholesterol, your liver, your kidneys, thyroid. I always call it an MOT to my patients. And you look at urine. I have not mentioned urine because we check your urine for any protein in your urine once a year as well, and your eyes once a year as well. So yeah, to answer your question, at least once a year, but your clinician may request it more frequently on a 3-monthly kind of staggered way. Maybe 3 monthly if they've made any dietary changes, recommendations, or dietary changes, or if we made any medication changes as well. So again, it's down to your individual clinician.
Thanks, Debs. There's a question here that says, what age do you usually prescribe the Emper, the ribosol, I can't even say it, and the metformin? And what age can I get a health check MOT? I'm 16. I mean, to be honest, I would say the NHS isn't brilliant about doing health checks. It's far more of a reactive service generally. So when people have got symptoms, so if you're feeling tired, thirsty, getting thrush, getting infections, any of those things that Deb's mentioned at the outset, then go and talk to your clinician, and please do say if what you're concerned about is diabetes, or in fact whatever it is you're concerned about, because that really helps us to know how we can allay your concern. So if somebody comes and says to me, I'm worried that I might be anemic, even if that wasn't something I was necessarily worried about, very easy to allay that fear by organising a blood test. So we wouldn't generally just be doing a health check on a 16-year-old to see whether or not you were diabetic, but certainly if you had symptoms that suggested that, of course we absolutely would want to do so. In terms of sort of an MOT, when you get to 40, people are able to book a health check, and usually that involves your blood pressure, your height and weight, and having your cholesterol and your HbA1c checked. But not all practices routinely offer that, although you can ask for it. I don't know if you want to add anything to that, Deb, because they definitely isn't an age thing about prescribing those particular medications, because really it's a clinical decision, isn't it? But at 16, that's, you know, that would you be
I wouldn't be
borderline to whether you'd be
comfortable.
type 1 or 2, really?
Yeah, you would need further investigations. It depends if you have symptoms, Jack, or if you've already had a diagnosis. But yeah, we would be referring you in, I suspect, if you were 16, and if you had a diagnosis of diabetes. That's a good question, actually. Is it 16 or 18 if you're still under the pediatric diabetic team? I'm not too sure.
I think actually 16 to 18 is when they do the kind of handover bit, and
There's
18 is when the
there's a young
endocrinologists
adult
take it.
service. Yes, I remember that.
Yeah. Yes, so I would say there aren't the drugs, there isn't necessarily a what age would you give something. It's much more based on your clinical presentation, what your HbA1c is and how you are. But for under 18s, we're much more likely to be wanting to get the specialist paediatricians involved, I would have thought.
Yeah, definitely.
And actually insulin, which we sort of touched on, I guess that would also be something that usually isn't started by primary care, even if you're a type 2. I think usually that goes into community as well.
Yeah, that's right. Yeah.
Yeah.
There's an add-on that Jack has added.
Yeah, I'm just aware about using names, although I know it's in the chat. When we do the recording, we'll be editing that out. It's we would try and avoid being really specific to individuals. So I think that, you know, actually it's quite important that it sounds like this particular person really does need to speak to a clinician. In terms of working out BMIs, there's a general a sort of thing. It is more difficult to work out the BMI in children, because there are height and weight charts, and it's not as straightforward as once you're an adult. So generally 18, you can just use the charts that are available online. There may be a calculator on the NHS website where if you put in your age, it would calculate around about what your BMI is. But I think in this sort of situation, you book an appointment with your GP, absolutely. Any other questions that we've got there? And if not, can I just say thank you everybody for coming and for listening in to this, really what I hope has been really informative talk from Deb's there. I've certainly really enjoyed it, and it's good to see so many of you here, and hopefully it will have empowered you and maybe made some of you think, let's go and take control and sort out a few lifestyle changes that might make a brilliant change to everything.
Yes, definitely. You can make such a change to your lifestyle. Very
Fantastic. Brilliant. Thank you, Debs. And
and
as I mentioned at the beginning, if you've got any young people or you yourselves are interested in a change of career, then look out for the newsletter that will be coming out shortly from the PCN. You can get all of this webinar and all of our other education webinars on our PCN website. And I believe we've got a benefits awareness webinar coming up later in the year, so look out for that. Have a lovely evening.
Thank you.
Bye.
Thank you. Thank you.